Hello, this is your brain on drugs, and this is the punk rock psychiatrist. Just getting started with today. We are going to be starting with the GLP-1 receptor agonist medications. I've got a lot of good stuff on these. I think you're really going to enjoy it. I've been updating these for years. A lot of these updates are very recent, and so you're going to get like the most concise, consolidated, um, comprehensive. If I don't know if that's like a paradox to have all those things at once, but about these medications. And today, what we're going to talk about is how do they work, and which is that won't take that long to explain. And then what are all the benefits? All right. And then next time, I think we're going to probably talk about uh, the risks and some other things. We're going to talk about dosing. We're going to talk about risks. We're going to talk about how to manage those risks. We're going to talk about all the different aspects that apply to these medications as a whole, and then we'll break it down and we'll go into each individual medication. We'll talk about the ones that are likely going to be approved in the future. Sorry, this episode is airing a few days late. I had a big move, so getting this out to you a little bit later. But let's go ahead and dive into this. So these medications, everyone knows them as, I mean, I have a huge pet peeve about people referring to these medications as Ozempic. That drives me absolutely freaking crazy because they're actually never, there is a drug called Ozempic, and they're never talking about that med. And so I don't know, maybe it's how the makers of Kleenex feel about everyone using the word Kleenex to refer to tissues when they're the brand name and you may be using puffs, or um, the Hoover, the Brits call a vacuum Hoover whenever you're using a different company's vacuum cleaner. But for some reason, people are simple and they like attach the word Ozempic to everything that has to do with these medications. But I'd say the most technical name to describe these medications, and because we're not just talking about GLP-1s, we're talking about GIP, we're talking about the glucagon ones that are going to be coming out soon. What these all have in common is they are incretin analogs, right? So an analog means that it's kind of like a manufactured, like chemically made version of something. Like it's similar to it. It's not the actual, like, like you could have melatonin that your brain makes, and then you could like make melatonin in a lab, right? So an analog would be the one that you like made. And incretin is just, it's a protein, it's a hormone. There's GLP-1s are incretins, GIPs are incretins. We're going to talk about what all those are and what all they mean and what they all do and what's different about them in the future. But we're just going to talk about incretins kind of in general to describe how these work. And so first I'm going to describe, like, I mean, these medications were originally created like in, was it exanatide was the first one. It was like 2002 or 3 or 4 or 5, something like that. It was a long time ago. I mean, it was before I was even in medical school, and I don't even remember being taught about it. Was it Bidurian? Was that the brand name? We're going to talk about it because historically reasons you're never going to use it anymore. But yeah, these were created for diabetes. So let's talk about how it affects our insulin glucose kind of system, right? So we'll talk about that first, and then we'll talk about all the effects it has on other parts of the body, right? Because we didn't start thinking about these for weight loss until, I don't know, 2012, 16, somewhere in that time frame. All right. So you eat something, right? You eat it, it goes into your stomach, it goes into your gut, and then what happens? You release incretin hormones. You have these things. They exist in your body. That's why the drugs that we're selling now, they're analogs, right? Like you have these, right? And these are things like GLP-1, glucagon like protein 1, and GIP as well. And so those get released, and then they have an effect on the beta cells and the alpha cells of your pancreas. All right, the beta cells can signal insulin secretion, right? Insulin is secreted from your beta cells, and the GLP-1, GIP, they signal beta cells to do this. Okay, And so insulin goes up. As a result of that, glucose is glucose uptake by the muscle occurs, and so your plasma glucose goes down, right? And we all know that diabetes is when your blood glucose is too high. So, and that's why people have to take insulin, that their insulin sensitivity is off, or they don't produce insulin because insulin drives that glucose down. All right, so these incretins, they stimulate this process. Also, glucagon secretion from alpha cells is decreased by GLP-1. It stimulates glucagon secretion in the alpha cells to go down. The effect of that is the glucose that's produced by your liver is decreased. All right, so your liver is like, oh, okay, because you have gluconeogenesis in your liver makes glucose, and essentially this GLP-1 is basically saying, hey, we don't need you to make glucose, we just ate some. All right, we got some coming down the pike, we don't need you creating any glucose here in the liver. And the liver's like, all right, I'm going to do it, and as a result, your glucose levels in your plasma go down, and so this is how it helps with diabetes. And this was kind of originally what these medications were used for. Now, they have a lot of other effects, right? So, and a lot of these other effects are effects on weight, okay? So those are effects that are just on your blood glucose. Now, let's go through each kind of system. We talked about the pancreas, right? So we'll start with the liver and the pancreas because we just talked about them. Kind of sum that up, right? So these medications, I was talking about the natural stuff. So the analogs do the same thing. They increase insulin sensitivity because insulin secretion is increased, glucagon secretion is decreased, insulin biosynthesis is increased, beta cell survival goes up, beta cell proliferation goes up. So we have more beta cells, and they're what's making the insulin, right? So that's what's happening in the pancreas. In our liver, our hepatic glucose production is going down. In our adipose tissue, so those are our fat cells, there is an increase in lipolysis, free fatty acid synthesis, and glucose uptake. And in the muscles, we have increased glycogen synthesis and increased glucose oxidation. So all those kind of metabolic things going on in our pancreas, our liver, our adipose tissue, and our muscle increase our insulin sensitivity. All right, so what's going on elsewhere? Well, let's go to the gut, right? What's happening in the gut? They decrease gastric emptying. So they're going to slow your food moving from your stomach into your intestines. That's going to cause you to feel full longer. So you're not going to want to eat as much. That is one method by which this causes weight loss. All right? It also causes increased acid secretion in your stomach and decreased GI motility, gastrointestinal tract motility. So not only are you emptying it more slowly into your gut, you're moving it more slowly through your gut. So you're not going to want to eat as much, right? Up in the brain, it decreases appetite and increases satiety. All right, so you feel full faster and you don't feel like eating as much. And it increases energy expenditures, and then so you're using more energy. So it's basically signaling your brain, hey, we just ate, we don't need to eat, right? Because remember, naturally this stuff is stimulated by eating, right? So it's just kind of like, all right, let's slow the process down, let's move this through, let's absorb it, let's get insulin going because we've got some glucose coming through our system because we just ate some food, and hey, we don't need to eat anymore, so like, hey, let's tone down that appetite, you're full now, right? So that's kind of how that's going. What's happening in the heart? Blood pressure, decreased blood pressure, increased heart rate, increased myocardial contractility, increased cardioprotection, right? We're going to talk about this today when we talk about like all the benefits of this. So it's good on our heart. Kidney, it's also good. It increases, what I have here is it increases natriuresis, which is like, that's, wasting of sodium into your urine. But overall, it like helps your kidneys. and we're going to talk about that too. So it has positive impact. So there are receptors for GLP-1 in your muscles, in your fat cells, in your liver, in your pancreas, in your gut, in your brain, in your heart, in your kidney, and it is having positive influence in all of these locations. All right, and so let's. I won't give away kind of the next thing. Let's talk about GLP-1 itself, right? So GLP-1 is something, right, that we create in our gut, right? It's produced in the ileum by the enteroendocrine L cells. So the ileum is part of your small intestine. You got your duodenum after your stomach, and then your ileum is like the more distal later part of your small intestine, and this helps with glucose dependent secretion of insulin, reduces inappropriate glucagon secretion, slows gastric emptying and digestion, leading to reduced appetite. Right, we already talked about that. So this is the GLP-1 that we're making ourselves in our bodies, in our ileum, all right, in our L cells. Okay, GIP is produced elsewhere. We'll talk about that when we talk about GIP later. All right, we're going like time wise. We're going to talk about GLP-1 first because that was the first one we kind of figured out, right? So, but here's the thing, right? So they started to learn about this and figure it out whenever they were doing these bariatric surgeries, and they noticed in this, they started studying it, that this endogenous GLP-1, so it's the GLP-1 that we produce ourselves, it's actually broken down too quickly to cross the blood-brain barrier. It only lasts like 30 seconds. So the GLP-1 that you're producing in your body, it has a very short impact on you. So all these crazy great impacts it's having, this is just, one hormone of many that's doing things inside your body, and most people are not going to want too much of this. Like me, as an average sized person, if I had too much of this, I would waste away because I would not have appetite, and I need to eat the amount that I'm eating. Okay. But for folks that have gained excess weight, eating less is what's going to help them get down to a healthier weight. And so having more of this in their system would be useful, but they don't have more of it in their system, right? So that's why we produce the synthetic GLP-1. The synthetic version is not broken down by DPP-4, right? DPP-4 is the enzyme that breaks down GLP-1. We actually have drugs for diabetes that are DPP-4 inhibitors. So you might think, oh, that would work kind of like a GLP-1. They don't really cause that much weight loss. They don't really affect it that much. I'm not exactly sure why. However, these synthetic GLP-1s are not affected by DPP-4. They're not broken down. They're allowed to get into all these different parts of your body and stay there longer, cross the blood-brain barrier, right? Turn down emotional rewards of food in the brain, leading to sustained weight loss. However, you should still enjoy food. A lot of people worry they're not going to enjoy food. I've heard of people not want. The thing is, you're just not going to want to eat as much. It doesn't mean that you're not going to enjoy what you eat. And so, where did this really originate? I don't know how many of you know about how this was originally discovered back in the 1980s when they first found the GLP-1 in the Gila monster saliva. So the Gila monster is a lizard that lives in the desert of the western United States. It is a large, tough, fat-tailed, kind of a purple color with orange stripes on it. It's poisonous, but this lizard only eats a few times a year, right? It can go months without eating, and it does this by it engorges itself. It eats half its body weight when it eats. It stores a lot of this energy in its fat tail with the fat. It has a very low metabolic rate because it spends about 95 to 98% of the time underground, not moving, not consuming energy. But what allows it to kind of be able to have this lifestyle is that it has long-acting GLP-1. And like when people studied this lizard, they were like, how is it able to not eat so much? And this GLP-1 was part of that picture. And then they isolated this chemical and studied it, and now here we are, like 40 years later, with these drugs. All right, so whenever people say that we need to pull money from science because we're studying some stupid thing that they think means nothing, that is like the dumbest thing you could possibly do. There is nothing more useful than pouring as much money into science as possible, because you never know where you are going to find something really, really amazing. Just to harp on that point, to put the plug in there for science. Another really interesting thing is the guy who discovered PCR, polymerase chain reaction, which is basically how we like do biology and genetics research. We like this technique is like absolutely vital. This was discovered in some sort of like heat resistant organism that lived on heat vents at the bottom of the ocean, and they had this enzyme like didn't break down in the heat of the vents. And so like in our process to be able to like do this research, it needs to be very hot, I guess, and like the chemicals we were using were breaking down, and so we weren't able to use it. And then he finds this like, oh, here's this creature that makes something that's heat resistant, maybe we could use that for this. And everyone thought, it's like, why are we wasting money on this guy studying these organisms? And then look what happens. We make one of the most important discoveries that we ever possibly could have imagined, that like we would have, there's so many technologies we would not have right now if he had not found that thing, right? You think studying the saliva of the Gila monster sounds like a dumb idea? Well, now you're probably taking a drug that exists because of it. So like trust science. We need to invest in science. So there's my science, a big science plug. So study everything. All right. And then the other thing about GLP-1 that people might be concerned about, that they don't need to be, it does not cause low blood sugar, right? So it lowers blood glucose, but so you might be wondering, well, it could lower it too much. If you don't have diabetes, this is not a risk. Okay. If you do, then it could be a risk. But if you're just taking this for weight loss, this is not a side effect you need to worry about. All right. The GLP-1s do not stimulate the pancreas to secrete insulin unless we're in a hyperglycemic state. All right. So all those effects that it had on those body parts, it's the pancreas is, it's basically gonna be like, yeah, I don't need this right now. Blood sugars are fine. And it'll be like, all right, I'm going to skip the pancreas and go work on this other stuff. Okay, so if someone has diabetes, though, they do go into states of hyperglycemia, and then they could be driven into states of hypoglycemia. Okay, so that is a concern. So these drugs work a little bit differently in people that have diabetes versus people that do not have diabetes. And we'll talk about that more later. All right, so I'm going to go through the plethora of benefits that these medications have. And I know a lot of people, they rag on these medications for all its downsides. We're going to address every one of those as well. All right. And some of them are serious and some of them aren't. Okay. And some of them are nothing burgers. All right. But so today we're going to sing the praises of GLP-1s. Okay. Lifespan. Let's start off the gate with the most important thing. Lifespan in the United States. Lifespan for men is now only 75 in the U.S., 6 years behind other developed countries. We are not living in the United States as long as other countries of similar economies and are living, right? Cardiac deaths related to obesity, and remember this when we were talking about obesity a lot earlier. The United States is much more obese than a lot of other countries. So cardiac deaths related to obesity increased 2.8-fold between 1999 and 2020. That's huge. Almost 3 times more cardiac deaths related to obesity in just 20 years, right? Mostly affected middle-aged men, black adults, Midwesterners, rural, people living in rural environments. Those were the most affected, okay? So these medications improve lifespan. How do they do it? Through a lot of these things that we're going to talk about here in a second. All right, so blood sugar control, we talked about that. So if you've got diabetes, 50% of diabetic patients attain a normal A1C on these medications. The Surmount trial, Surmount 1, which was a tirzepatide trial, showed the risk of diabetes was reduced by 94%. So if you don't have diabetes and you're obese and you take this medication, you are decreasing your risk of diabetes significantly. All right, so blood sugar control. Next, fertility. So fertility is improved in both males and females. In females in particular, there's improvement in polycystic ovarian syndrome, PCOS. This is because there's the weight loss and improved insulin resistance improves PCOS symptoms, and improved PCOS symptoms lead to improved fertility. I talked about how it's good for the kidney, renoprotective. So you have GLP-1 receptors on the afferent arterioles inside your kidney. GLP-1 influences secretion of angiotensin 2 and improves oxygenation. Angiotensin 2 is related to blood pressure. There's a 24% relative risk reduction in kidney events on these medications. So good for the kidneys. All right, let's talk about the heart. A lot of stuff with the heart. Cardioprotective, protects the heart. How does this work? The weight control, the glucose control are part of it. There's an anti-inflammatory stuff going on. There's improved capillary health due to anti-inflammation and reduced atherosclerosis. And we've got a trial here with semaglutide, 29% relative risk reduction in cardiac death. And that study was only done on 1 milligram of semaglutide versus 2.4, which is the current max dose on Wegovy. So the study ended early, actually, as not to deprive patients of life-saving medication. So the true benefit may be even more than that, right, at a higher dose, and if we had actually been able to do the trial all the way through. And the adverse events in this trial were similar to placebo, so they didn't see like increased amounts of adverse events compared to the placebo group. On tirzepatide, the study showed 38% relative risk reduction of cardiac death. That's pretty big, right? And that there is a direct effect on sinus node versus the sympathetic system, which is seen in other obesity meds that increase heart rate. Remember how I was going through all that stuff and I was saying like, oh, it decreases blood pressure, increases myocardial contractility, and increases cardioprotection, all good. But then I also said increases heart rate. I mean, that's not a good thing, right? So that's because it has a direct effect on the sinus node, that's the part of the heart that like kind of tells it to like fire its electrical signal to beat. However, this negative effect is likely outweighed by the other stuff. So the good stuff outweighs the bad stuff. So even if it does do this, the cost outweighs the benefit, or the benefit outweighs the cost, right? Sleep apnea. So tirzepatide in particular actually received FDA approval for moderate to severe sleep apnea in 2024. So these medications are approved for 4 things currently. They are approved for weight loss. They are approved for diabetes type 2. Tirzepatide is approved for sleep apnea, and that was 2024. And then last year we got a 4th approval. We haven't talked about it yet. There's a 4th one. I'm going to talk about that in a second. So approved for sleep apnea. The AHI, right? That's the apnea hypopnea index. There was a drop of 25 to 29 points versus only 5 with lifestyle changes. That is massive. Let me tell you, 25 to 29 is huge on this scale. Like, I mean, you have severe sleep apnea at like a score of something like 15, right? So it's like, what is it like? It's around, I think it's like mild is like 5 to 12, maybe moderate is like 12 to 15 or 18 or something, and like above that is severe. So when you're having a 25 to 29 drop, that means that you are, and you're thinking, okay, what is this scale? It's not even really a scale. It's not a scale. It's an actual measurement of something happening in your body. So the AHI is a measurement of how many times are you stop breathing per hour, plus how many times is your oxygen dropping below 90% per hour because you're not breathing enough. Okay? How many times per hour is that happening? If it's 30 times per hour, that means every other minute you like stop breathing or almost. So if your scale's dropping by 25 to 29 and you had like a 30, that's pretty much gone, right? I mean, you could have more. I've seen 60, 80, but like that is a huge drop, right? Say it was 60. You stop breathing every minute. Now you're only stop breathing half the time. That's a pretty big improvement, okay? And that was just the average. And then the placebo was only 5. So like a lot of the time, especially with psychiatric drugs, when we compare things to placebo, there's not a huge difference. That's a huge difference. All right, there was a 43 to 52% resolution in sleep apnea versus only 15% with lifestyle changes. That is a massive difference. Okay, well deserved of an FDA approval. Okay, next, knee arthritis. Here's a study. Once weekly semaglutide in persons with obesity and knee arthritis, 2024. 68-week studies, really long, double blind, placebo controlled, loving it. 61 sites, 11 countries, well designed. 407 participants, average BMI of 40.3, quite high, average age of 56, pain score 70.9 out of 100. These patients had a 13.7% weight loss versus only 3.2% on placebo, and their score on the pain scale dropped by 41.7 versus 27.5. So look, they're like a 70 out of 100. So like we'll just say 7 out of 10 pain, and they went down by 4, so now they're 3 out of 10. Okay, I mean placebo did drop by 27, so they would have gone to like what, 4.5. So a 3 versus a 4.5, that's pretty substantial, especially on average. So and that's just measuring knee arthritis. Amongst everything else that's improved, that's pain from knee arthritis, absolutely improved. We've talked about cancer risk with obesity. There are 13 cancers associated with obesity. Currently, we are aware that 10 of these 13 cancers associated with obesity have been demonstrated to be reduced by GLP-1s. It might be more. Why wouldn't it be all? But we already have evidence that 10 out of these 13 cancers associated with obesity are improved with GLP-1s. And one of the most important ones, colorectal cancer. That one's getting really bad. I don't know if you've noticed this, but like younger and younger people are getting this. It's lifestyle diet related. It's probably too much like processed meats and junk like that, too many hot dogs, right? That's why they decrease the age that you're supposed to get your colonoscopy from 50 to 45. So what did we see here? There was a reduced risk of early onset, that's age under 50, colorectal cancer in patients with diabetes type 2. Cohort study with 1.8 million patients with diabetes type 2, 77,000 patients per group. 0.4% risk versus 0.7% risk regardless of weight. 0.4% versus 0.7%. Other studies have shown decreased risk for late onset colorectal cancer as well. So the risk drops from like 0.7% to 0.4%. That is meaningful, right? I mean those are small numbers, but like most people don't get colorectal cancer, right? So this is patients with diabetes. Like 0.7% of them were getting colorectal cancer. Now it's only 0.4%. So you've essentially cut that risk in half, right? Next benefit, weight loss, of course, right? And we're going to talk all about weight loss. I mean, that's what this whole dang series is about. So we'll talk about that later. Weight loss in patients with diabetes type 2 is less than those without, likely due to more diet advice given in weight loss trials. So the studies show less weight loss, but that's probably because we were looking for it and monitoring and designing the study more for that. So it's not necessarily true that just because you have diabetes, you're not going to have as much weight loss. There are preliminary studies that show improvements in drug abuse and other behaviors, addictive behaviors, like gambling, hypersexual behavior, skin picking, nicotine use, okay? And then let's talk about alcohol use disorder. We're mounting evidence for this. I mean, it may even get approved for this at some point. So there's some rat and monkey models show decreased self-administration of alcohol. There's anecdotal reports of those taking for other means, they're taking it for weight loss and they're saying, hey, I don't feel like drinking as much. And then we had a study last year, really great one, Swedish registry study, repurposing semaglutide and liraglutide for alcohol use disorder, 2025, 227,000 cohorts, 16 to 64 with alcohol-related disorder between the years of 2006 and 2023. 8,000 of them were taking a GLP-1 receptor agonist. Those taking the GLP-1 had 1/3 lower risk of hospitalization for alcohol-related disorders while they were taking a GLP-1 than those that were not. All right? FDA-approved medications for alcohol use disorder only have a 2% reduced risk for hospitalization. This is a 33% risk. So this is better than naltrexone, right? This is better than everything else we have. However, the study had some limitations. Lack of racial and ethnic diversity. There were only 6% non-European ancestry. Remember, this was done in Sweden. Reliance on diagnosis from the medical record. So it wasn't like, this was not like a prospective study. It was like a retrospective study. Broad definition of alcohol-related disorders, not restricted to alcohol use disorder alone. So I think that percent is so high that, and like, we see this, right? Those of us that treat alcohol use disorder, that have seen this, we're seeing this. Okay, this is going to be a big. I'm telling you, this is going to be something that's going to be probably FDA approved, I think. Oh yeah, let's talk about MASLD, metabolic associated steatotic liver disease. Man, I don't have that written in front of me, by the way. When I read out these acronyms, I'm like memorizing these off the fly. And you're probably thinking, of course you are. You're a doctor, right? It's hard to memorize all these things. I'm a psychiatrist, for God's sake, So, semaglutide, 72-week Essence trial, liver, fatty liver. This used to be called non-alcoholic fatty liver disease, right? But now it's metabolic associated steatotic liver disease. So, 63% versus 34% placebo resolution. So 34% of placebo had resolution, 63% on the GLP-1. That's huge. Because of this, this is our fourth FDA approval. It's not for MASLD, it's for MASH, metabolic associated hepatitis, right? So you actually have to have the hepatitis associated with fatty liver, and not just the liver, just fat in your liver. So it's only for MASH that has FDA approval. But you've got an obese patient that's got MASLD. Their MASLD is going to get better because you can give it to them for the obesity, and then they get the side benefit, right? So, but if they're not obese and they have MASH, you can give them the drug because it's FDA approved, right? So it's for MASH with moderate advanced fibrosis. That was approved in 2025. Tirzepatide is also being studied for this. Smaller phase 2 trial, 62% versus 30% placebo resolution. So pretty similar results with tirzepatide. We may be seeing that one also approved for this as well in the coming years. All right. Let's talk about the brain. So we know that it improves plasticity, synaptogenesis, and anti-apoptosis. Those are all things that make your brain healthier. It makes your neurons join together in healthier ways and change and keep your brain nice and healthy. They've looked at dementia. This is actually one of the ones we did not find anything on. So, but the theory was good. Amyloid causes inflammation, oxidative stress, and mitochondrial dysfunction. GLP-1 is anti-inflammatory, antioxidative, and dissolves amyloid. So, hey, this should help. They do this EVOKE trial. No benefit was found. Maybe we'll find something in the future. Maybe one of these newer drugs will help. But for now, it looks like it has healthy effects on the brain. But what's the payout? We don't know yet. There was a study on this one's hard to say. Lixisenatide. You probably never heard of that one. It's not really. It's only available as a combo now. It used to be it's an older GLP-1. They pulled it because I guess it wasn't making any money. It's now combined with something else. We'll talk about that one. That one was actually shown to slow Parkinson's disease in mice. And then here we have a study of clozapine, our antipsychotic, mixed with semaglutide, phase 2 trial results with positive results on weight without worsening psychosis. So, we get a lot of weight gain with clozapine, and so adding the semaglutide, no positive results on weight. So that's good. All right, so that actually wraps all that up. That was a shorter episode than I was expecting it to be, but yeah, I think that's a good start for us on the GLP-1s. Now you know how they work, how they affect so many different things in the body, how we think that it's having those effects, and then like what the effects it's having on all these different parts of the body are. And like, I don't know, to kind of sum it up, like for most of you are probably listening to this podcast because you're mental health people, right? And you're thinking like, what is this going to do for me? Why should I know how to use this? And it's like, I think it's that last point we talked about, clozapine plus semaglutide, phase 2 trials, positive results on weight without worsening of psychosis. We deal with a lot of obesity, okay? We cause a lot of obesity. We need to, because like these patients need these medications to treat like severe diseases. And so we're causing it. We've got folks that like, because of their mental illness, it's causing them to change their lifestyles to where they gain weight. I think I may have talked about this before. There was a study they did where people that were stressed, and they had depression, they were admitted to the hospital, and they weren't eating, no appetite. They gained unhealthy weight. They actually lost weight overall, but they were losing muscle, but they were still gaining fat. They were gaining visceral fat even though they weren't eating, right? So mental health conditions cause obesity. Our medications cause obesity. Patients that have mental health problems become obese. People that are obese are at higher risk of mental health disorders. Some people have the mental health disorders because they're obese, because them not being happy with themselves and how that's affecting their life can lead to depression, anxiety. And remember, a lot of these antidepressant medications, they don't work for everyone, right? Like at best they work for like at absolute ideal states, these medications work for 2/3 of patients that have like legitimate actual like depression that we can determine is like not lifestyle, not adjustment disorder, just depression. Our meds only work on 2/3 of these people. That's why I'm always saying you need to find the root cause. Okay, why are those 1/3 not responding? And it's probably more. Like, why are they not responding? Is it because they have sleep apnea? Is it because they have a thyroid problem? Is it because they have obesity? Okay, so maybe the thing to do to treat their mental health condition is to treat their obesity. And do you really want to farm that out to their primary care? Are they going to do it, or give it to someone else? When are they going to get that endocrinology referral in, or whatever? When are they going to see this doctor? Is this doctor going to be comfortable doing this? Are they going to have the time that you have to explain things to the patient and manage it and like go over all this stuff? Or are they just going to slap it on there, set it and forget it, and not know what the heck's going on, and something bad happens? Why don't we keep some of these patients to ourselves? And the other thing is, all these other meds that we've talked about up to this point, they're all mental health meds. They are. We got bupropions in there, naltrexone's in there, phentermine, topiramate. These are, you've got Vyvanse, the amphetamines. These are all mental health drugs. Like, we already know how to treat this condition with all the other medications used. The GLP-1, the incretin medications, they are the most effective. They're the ones most likely to work. And it's like, don't just drop off at, okay, well, I knew what to do with these. I gave you metformin, I gave you topiramate, it didn't work. I don't know what to do. I guess we can't do anything about it. And all the while I'm giving you clozapine and you've gained 150 pounds. You can give them the GLP-1. And the thing is, look at all these benefits you're giving them. I mean, you're giving them benefits on lifespan. You're giving them benefits on, you know, a lot of our meds cause diabetes, our antipsychotics. You know, we're helping prevent that, right? You're not just fatalistic, like, well, I guess they're just going to get diabetes. Not if they're on GLP-1, maybe, right? Fertility, we're helping their kidneys, we're helping their heart, we're helping their sleep apnea. There's so much sleep apnea patients that we see, arthritis, cancer risk, weight loss, the body image, alcohol use disorder. How many of our patients have that? Liver disease, like how we pay attention to liver disease. A lot of our stuff affects the liver too, and then effects on the brain. Like, to me, this stuff is right down psychiatry's alley, and that's why I've been interested in this for like the last 4 years, because this is right down our alley, and I'm trying to sell you on it. Get comfortable with these, learn about them, and you know, and don't go willy nilly like everyone else is doing. Listen to this information. So now you know, like, all the great things that these medications can do. Next time, I'm going to talk to you about how to dose them. Like, I'm going to basically teach you about the life course of these. How to dose, how long to treat, what are the contraindications, what are the adverse effects, how it is affected by all these other factors. That'll probably be a couple episodes. So basically, all the ins and outs of how to prescribe them and how to be careful. Like, so the next 1 to 2 episodes, what you're going to learn are all the things you need to look out for when you're prescribing these meds. Everything you need to monitor, everything you need to be careful about. And if someone has a question, you're going to have the answer on how to tell them, like, the answer to, you know, their question of, like, oh, will this hurt this problem, or will this cause this problem? You know, you're going to get that information. So, like, today's episode was about, like, these are great, you should use them. Next 1 or 2 episodes are going to be like, if you were worried about it, you don't need to be, because I'm going to tell you all this stuff. And then after that, I'm going to start going through each of the medications and tell you the ins and outs. How is one different from the other? When would you use one versus another? And we'll do that breakdown like we always do. Okay? So I think you're really going to get something out of this, and I just really want to encourage psychiatry out there to prescribe these medications. So I want to thank you so much for joining me today. Please tune in next time. I think next time is going to be, you know, if you're a prescriber or you're like a nervous person who takes these medications and you want to be reassured on, like, how to do these properly, that is going to be the episode that is going to be the one you like the most. And I'll see you next time.